Good morning, everyone. I thank Neeraj for including me in this, and I'll be speaking on intravitreal injections. So once we have this devastating complication, we need to be aggressive with our treatment. And as Dr. Ajay Arora had showed you some very nice pictures and was telling the importance of documenting and acting fast when we see a very aggressive infection sitting on our head. So we have to confirm by doing an ultrasound B scan where we can see significant exudates in the vitreous cavity, which were usually low to moderate reflective, and we have to make sure that the retina is attached, and we have to also see the choroidal status. Any case where there is a clinical suspicion of endophthalmitis should raise your alarm bell, and if vision is more than hand motion and vitreoretinal facilities are not available, sometimes the vitreoretinal specialist may be far off and you just need to buy time. So it is at that time when you need to give intravitreal injections just to get over the time till the patient can reach a vitreoretinal facility. And also at the completion of vitrectomy you give intravitreal injections. So they are the mainstay, and systemic antibiotics do not reach the intravitreal cavity because of the blood retinal barrier, we all know that. And the intravitreal injection is able to bypass this barrier and thus provide a good concentration locally where it is most required to prevent destruction of retinal tissues and the intraocular tissues. So what is the ideal agent for the intravitreal injection? It is effective against offending organisms. It is non-toxic to retina in bactericidal doses. It should have an appropriate half-life within the vitreous, and it should be injected prior to the irreversible destruction of the retina, and it should be easily available and cost effective. So some of the drugs are for the gram-positive cocci, vancomycin is the preferred drug. For gram-positive bacilli, again vancomycin is the preferred drug. However, for gram-negative cocci and bacilli, ceftazidime, amikacin and gentamicin are the preferred drugs. So these are the drugs which are usually used. In the end, you can see that there's a steroid which I have listed. So if we do a KOH preparation from the aqueous tap and we see that there is no fungus, then we can give an intravitreal injection of dexamethasone to decrease the inflammation along with the intravitreal antibiotics. When we use a true drug regimen, then some of the common combinations that we use, for gram-positive organisms we use cefazolin and vancomycin. For gram-negative we can use amikacin and ceftazidime, and for fungal we use amphotericin B and voriconazole. So these are the various drugs and their doses which are commonly used as intravitreal injections for endophthalmitis. And usually these drugs are prepared by dilution method. Vancomycin is available as a 500 milligrams powder, so it is reconstituted with sterile water for injection, 10 ml of this water, and then we withdraw 0.2 ml. I'll be showing you a video for this. We withdraw 0.2 ml of this into a tuberculin syringe. We change the needle and then draw 0.8 ml of saline or distilled water in it for dilution. And after mixing, we discard the rest and use only 0.1 ml of this. So we achieve a concentration of 1 milligram. Similarly, ceftazidime is again available as a 500 milligram or 1000 milligram powder, and we reconstitute it and inject 2.2 ml of saline for the 500 milligram vial and 4.4 ml for the 1000 milligram vial. Draw 0.1 ml into a tuberculin syringe, replace the needle, and then dilute it up to 1 ml with 0.9 ml of sterile water for injection. And we discard all the rest but inject 0.1 ml which contains 2.25 milligrams of ceftazidime. So this is how we prepare that. Similarly, we prepare amikacin, and we can prepare amphotericin B with the dilution methods. I'll just show you a video shortly. Dexamethasone, you just have to withdraw 0.1 ml of this pre-prepared solution, and that is equivalent to 400 micrograms of dexamethasone. So the principles are that the must prepare these solutions himself using the printed reference sheet which Dr. Ajay Arora was showing, which should be there in all the operation theatres and all the OPDs. It is available from the AIOS website. Aseptic precautions should be taken, informed consent should be there, and wound integrity again has to be taken care of, and also take care of the suture abscesses and the IOP. So after preparing these injections in 3 separate tuberculin syringes and applying topical anesthesia drops, povidone iodine is used, and after draping, a lid speculum is used and the drug is injected. An AC tap or vitreous tap before injection should be taken to see what organisms are involved and their sensitivity, because these organisms may not be sensitive to the drugs that you're planning to give, and you may need to change those drugs if a repeat intravitreal injection is required once you obtain the sensitivity. The site of injection is preferred is the infratemporal quadrant, 3 mm away from the limbus in aphakics and pseudophakics, and 3.5 mm in phakics. You should stabilize with a cotton-tipped applicator, and the sample should be sent for a direct smear, cytology, gram stain, bacterial culture and sensitivity, and KOH preparation for fungus. Entry for the injection is with a 30 gauge needle. It's a pars plana entry to reach the mid-vitreous cavity. Bevel of the needle should be pointing away from the macula, and inject the antibiotic into the vitreous cavity drop by drop, and the second injection should be given with a different syringe. You should not mix the drugs, because some of these drugs, they can interact and it can get spoiled. So I'll just show you the video now. So this is how the trolley looks like, and you can see the 3 tuberculin syringes with the needles, and also here you can see the 3 30 gauge needles with which you will be using to inject the drug, the calipers and the bowls with the povidone iodine. So this is, we are reconstituting the vancomycin, and it should all be done in a sterile manner. And the other one is the ceftazidime injection. So the method and the volumes I have already told you. So make sure that it is mixed well, and then withdraw 0.2 ml for the vancomycin, and then using a different needle you have to take sterile water for injection. In this video, it's an older video, so they show you that it's you can use the saline from the bowl, which should not be done actually. Ideally it should be a sterile water for injection. So this should actually not, it's not recommended to do it like this. You should use a fresh sterile water for injection. So withdraw it up to the 1 ml mark, and then you will see how an air bubble will be taken and used for mixing the drug, which is a very important thing, because intravitreal concentrations are very, the eye is very sensitive to intravitreal concentrations of the drug, and by not mixing, so you can take an air bubble and then gently tap, allow the air bubble to go from down upwards, and then again come back when you make it erect. So by this these movements, the drug is mixed. There's a little bit of it's too bright here. I'll just go to the last part where you can see, actually because of the bright light you can't see, and here you'll be able to see the injection being given. So after all sterile precautions, the patient has been draped, and 3 millimeters in pseudophakics and aphakics, and 3.5 millimeters in phakic patients. Temporal quadrant you prefer, and after marking with the caliper, you enter with the 30 gauge needle and with the bevel upwards, and you inject slowly, and then you keep a cotton tipped applicator ready for injection. So I'll just go back to the last few slides that I have. So this is how what kind of response we can get. This was a case after AC wash and intracameral and intravitreal antibiotics. The middle picture you can see there is good resolution, and 4 months after treatment, you get a good result. So what is the definition of improvement? Improvement of vision, however small it may be, reduction or disappearance of hypopyon, clearing of the AC, consolidation of the fibrin exudates or shrinking of the pupillary membrane, a better red reflex, reduction of pain, and decrease in lid edema and chemosis. These are all signs of improvement. So a patient with 6/18 vision gets a vision of 6/6 with a good response after intravitreal injection. And this is another patient showing a good response after intravitreal injection. So what is the take-home message? That timely diagnosis and treatment of post-op endo can save most of such eyes. And endophthalmitis once suspected, the cataract surgeon should start patient on conservative treatment with intravitreal injection of antibiotics and send the patient to the friendly VIA surgeon for further management. Thank you.